Okay, hello everyone and welcome. This is our Wednesday webinar presented by the Association for Healthcare Denial and Appeal Management. We are recording our webinar today, as we always do. We will have the recording up on our website typically within a week, usually quicker than that. So if you aren't able to stay for the full thing or you want to listen to it again, you can find that on our website. We have AJ here with us today assisting with any technical issues. If you're having any problems during the webinar, you can put in your question under the questions tab and he will assist you with that. Otherwise, let's go ahead and get started. So today we're going to talk about the power of standards of care within doing medical necessity appeals. So a little housekeeping to get us started. If you're new to GoToWebinar, you have a control panel on your screen and you can open and close that control panel through this little red arrow here that I'm circling with my mouse. That control panel allows you to choose if you want to listen through your speakers. Microphone doesn't matter because you're all muted as attendees, or you can call in through the telephone, and the phone number was on the first slide there. You can also download the handouts. Go to the handouts drop down. You can download the handouts there, and you can also enter questions. So if you have questions for Dr. Smith or I today, we are your presenters today. If you have questions about the content, go ahead and enter them under the questions, and we will do our best to answer as many of those as we can at the end of the session today. If we're not able to answer all of your questions, we do a little follow-up presentation that, I guess it's a presentation, it's kind of a little slideshow that we put together to answer those questions we didn't get to, and we upload that on our website as well. Typically within a couple of weeks, we'll get that up there for you. So you can go ahead and answer your questions there if you have questions about the content. Now, I know sometimes it's difficult to download the handouts because you may be on a computer at work and they may not allow pop-ups or downloads or whatever. You can also go to our website and you can download them from there. I'm going to see if I can show you that here. Okay, so here is our website. If you just scroll down to here is our little advertisement for the webinar today. You'll see the slides are here, and you can click this little download link right here on the left-hand side underneath the slides. It may look a little different to you depending on which browser you're using. It does look different in different browsers. But you can download the handouts there, because I know y'all like to have them prior to listening to the content today. Okay, so you can download them there, or you can download them from within GoToWebinar. All right. So continuing with our housekeeping, let's talk about CEUs. We do offer free CEUs if you are an ADAM member. So you have to be a member as of today, and you will get a CEU for attending the webinar. You have to be on for at least 50 minutes. And then there's also a survey that pops up at the end of the webinar. It'll pop up automatically for you. You don't have to do anything. As soon as you leave the webinar or I end the webinar, it will pop up on your screen for you. Complete that survey. And it takes me about a week to go through and make sure, look at all the attendees, make sure you are an ADAM member, make sure you did stay on for 50 minutes, make sure you did complete the survey, and then the CEU certificates will be emailed out to you. If you're watching this as the recording of the live webinar, we don't provide CEUs for watching the recording. And as a disclosure, there are no individuals in a position to control content for this activity that have any relevant financial relationship to declare. Okay, for the CEUs, when you fill out that survey, it will ask you which CEUs do you want. You can select as many as you want. We have NARI, CCM for case managers, HEMA, ANCC for nurses. Now, I did apply for active, and we typically always have active CEUs, and they're usually Johnny on the spot and approve them right away when I apply, but there seems to be a hiccup this time around, and I have not gotten approval yet from active for CEUs for this particular webinar. So I'm going to keep working on it, and hopefully they will go ahead and grant them, maybe, retrospectively, or maybe even later on today. So you can go ahead and ask for the active CEU if you're interested in it, but I can't promise that we're going to have that available for you. So I apologize for that. Like, I know it's active week, it's CDI week, and I know they're very busy with that as well. And that could just be why I haven't heard back from them. So I'm working on it. Okay, and then our next webinar, which you should be able to go, actually you can go to our website right now at adam.org and sign up for it. It's going to be finding appeal success by creating your own evidence-based guidelines library. So we're going to be talking a lot about evidence-based guidelines today. That's basically what the majority of our presentation is on today. So in November then, on November 3rd, I'll teach you how to create your own library of evidence-based guidelines that you can pull from and use in your medical necessity appeal arguments. And that should give us enough time to slip one more webinar in before the end of the year. So we'll try to get another webinar in around the middle of December, if we can, to round out the year. A little bit about ADAM, the Association for Healthcare Denial and Appeal Management. We are the nation's only association dedicated to healthcare denial and appeal management. We've been in existence about 18 months now. Our mission is to support and promote professionals just like you all who are attending today, who are working in the field of healthcare insurance denial and appeal management through education and collaboration. And our vision is to create an even playing field where patients and healthcare providers are successful in persuading medical insurers to make proper payment decisions. And I'm hearing that a lot lately. I see that a lot in the industry right now, or in the community, talking about evening the playing field between payers and providers. And that's what we want to do by making sure we're all educated, well educated in this field. So this is me, Denise Wilson. I'm Senior Vice President of Denial Research Group and Appeal Masters. I'm also President of ADAM. I've been in healthcare for over 30 years, and I've been in denial and appeal management for about 17 years now, I think. So basically, my entire career has been in healthcare, and I do a lot of teaching and educating on denial and appeals. Hey, Dr. Kendall Smith is here as well. He's going to do our color commentary on our presentation today.
The talking parrot.
He is the parrot on my shoulder.
Right.
He's the Chief Physician Advisor at Denial Research Group of Appeal Masters. He's also an advisory board member at ADAM. He's a senior fellow in hospital medicine and a leading appeal educator and appeal services provider. He's been deeply involved in denial and appeals management through his hospitalist career. And he's also designed and implemented a number of CDI programs, including those at Cleveland Clinic in Florida and MedStar Washington Hospital Center in Washington. He has served as a physician leader on hospital revenue cycle management teams, while also serving as a physician advisor for clinical resource management. He's also an ICD PCS approved trainer. Okay, disclaimer, and then we'll get into the good stuff. The Association for Healthcare Denial and Appeal Management publishes and distributes materials on its website that are created by our members or invited industry subject matter experts for the benefit of all ADAM members. ADAM does not certify the accuracy or authority of these materials. These materials are distributed and presented as research information to be used by our members in conjunction with your other research deemed necessary in the exercise of your independent professional judgment. ADAM claims no liability in relation to reliance on the content of these materials. The views expressed in the materials are the views of the materials authors, do not necessarily represent the views of ADAM. Any references are provided for informational purposes only, do not constitute endorsement of any sources, and there's no conflict of interest to declare. Okay, so let's get into it. Our learner outcomes for today, at the end of the presentation, you should be able to make use of standards of care in the medical community to support and appeal argument that the services you provide for the patient are medically necessary and appropriate. You should be able to define a standard of care in the medical community. You should be able to describe 2 strategies for researching standards of care, and then appropriately incorporate standards of care and medical necessity appeal arguments to support the services were appropriate and medically necessary. So let's start at the beginning. I always like to make sure that we're all on the same page, we're all speaking the same language and understanding what we're talking about. So when I say standards of care, I'm talking about what has been defined by medical experts in the field as far as what is the standard of care to treat a patient who presents with any particular problem or problem. So they're also known as evidence-based guidelines, evidence-based medicine, clinical practice guidelines. I most frequently say evidence-based guidelines or EBG, so that's what you'll hear me say most often. But they're called a variety of different things. So I don't want you to get hung up on the terminology. And I also don't want you to get confused between clinical practice guidelines, which are published by medical experts, and clinical practice or clinical policy bulletins, which are published by payers. Okay, so CPGs and CPBs are 2 different things. And I think that's one of the reasons why I use EBG more so than clinical practice guidelines. I don't want you to get confused on the terminology there. Let's talk about a couple of definitions of what clinical practice guidelines are or standards of care. And this comes from the National Institutes of Health that describes or defines clinical practice guidelines as systematically developed statements about appropriate health care for specific clinical circumstances. They are issued by third-party organizations and based on evidence from a rigorous systematic review and synthesis of published medical literature. So it's not just any article that you find out on the interweb that you Googled. Okay, clinical practice guideline is systematically developed, goes through rigorous systematic review. And guidelines, as we all know, are not fixed protocols. Okay, they're just there for the healthcare professionals and providers to consider as part of, how they care for their patients. They're not to be used or not presented as a substitute for the advice of a physician or other knowledgeable healthcare professional or provider. So it's kind of a 2-edged sword because we talk a lot about things like interqual and Milliman. We're going to touch on those today as well, or MCG, as being, they're really not, I guess they're called, we talk about them as guidelines. They're really screening tools. They're not, I don't really think of them as clinical practice guidelines like I do what, is described here by National Institutes of Health. But you can say about Interqual and Milliman that they're not fixed protocols, that they are not intended to be a substitute for the advice of a physician or the care of a physician. But our payers can argue that back as well, that clinical practice guidelines are not presented as a substitute for the advice of a physician or other knowledgeable healthcare professional. I know Dr. Smith will want to chime in on this as well, that of course we have to always consider all of our patients have complex medical needs, most of them. Some of them have simple medical needs. Every patient is different. Every situation is different. You can't follow just a fixed protocol to care for a patient.
No, and Denise, we'll get into that, I think, a little bit further in this, but it's certainly what you're describing is the idea that a one-size-fits-all guideline is never going to apply to a specific patient. So a little bit further in the discussion, we'll take a more in-depth look at how some of these practice guidelines may fall short and the use of turning to medical literature to find things that better support your individual case at hand. And we'll take a deeper dive into that in just a bit.
Okay, this one I like as a simple definition of clinical practice guidelines. This comes from the Institute of Medicine that was published in 2011, and it's article they published called Clinical Practice Guidelines We Can Trust. So they are statements that include recommendations intended to optimize patient care, informed by systematic review of evidence and assessment of the benefits and harms of alternative care options, because that's something that has to be considered as well. Did you consider other care options alternative to what you're providing to the patient, and understanding what the outcomes might be from those alternative care options, and it's something you have to, we're very much, in the last couple of decades, focused more on making medical decisions with patient involvement. What does the patient want? What do they want to have done? And understanding, if you go down this route, this might be our outcome. If we go down that route, that might be your outcome. So I like the way they have included that. They are guidelines that include benefits and harms of alternative care options. Okay, and that article goes on to say this is what we look at to understand whether guidelines are trustworthy or not, because again, as I said, we're not just going to use any old article that we find on Google. A systematic review of existing evidence developed by a knowledgeable, multidisciplinary panel of experts, representatives from key affected groups, and that doesn't necessarily always mean physicians. I always think of the physician professional societies as kind of the first place I go. But we also want to think about dietitians and physical therapists and occupational therapists and speech therapists. They have guidelines as well as to how patients should best be treated. Consider important patient subgroups and patient preferences. Again, let's think about what does our patients prefer for their care. They should be based on an explicit and transparent process that minimizes distortions, biases, and conflicts of interest. So be very transparent about how they develop their guidelines. They should provide a clear explanation of logical relationships between alternative care options and health outcomes, as I've just stated. Provide ratings of both the quality of evidence and the strength of the recommendations. Now, some guidelines you'll see some that will provide the ratings, very formally provide ratings of and strength of the recommendations. Some do and some do not. And then be reconsidered and revised as appropriate. So they should be up to date or updated as care practices change. So let's talk about this. What is the significance behind standards of care, and why are we talking about this today? And when it comes down to it, any time that you are arguing the medical necessity of care, whether that's the medical necessity of admission to the hospital or medical necessity of services, therapies, medication, anything used to treat a patient, as long as you can argue that the care provided to that patient represents the standard of care in the medical community, payers should pay for that. I mean, that's the simple, down and dirty, short answer as to why standards of care are important. So if you have surgeons who are amputating paper cuts, oh my gosh, I'm getting my words all twisted around, amputating fingers for paper cuts, and you think you're going to get paid for that, of course you're not. But if you provide care according to what is accepted as the standard of practice, then you should get paid for that. So let's talk about Medicare first. This comes from a document called the HCFA 95-1 ruling. HCFA is the old name for CMS. It used to be called the Healthcare Finance Administration. It's now called Centers for Medicare and Medicaid Services, or CMS. But this came out in 1995. That's the title of 95-1. This still stands today. And what Medicare says in this particular publication is that when the Medicare contractors are trying to determine what's an acceptable standard of practice in the local medical community, now, why do they need to determine what's the acceptable standard of practice? They need to determine what's the acceptable standard of practice because they're going to publish what's called local coverage determinations or national coverage determinations. Actually, the contractors do the local coverage determinations that say, they're publications that say, this is when we will pay for your services, and this is when we won't. We'll pay for that total need when we see bone on the x-ray, when we see the patient has participated in physical therapy for a certain amount of time, et cetera, et cetera. So in developing those payment or policy or coverage guidelines, they have to take into account what is acceptable standards of practice, because that's what they're going to pay for. They're going to pay for acceptable practice, not unacceptable practice. So when Medicare contractors, when they're determining what's acceptable standard of practice, CMS has told them they need to rely on published medical literature, consensus of expert medical opinions, consultations with their medical staff, medical associations, local medical societies, other health experts. And they go on to define what they mean by published medical literature. So they're saying that scientific data or research studies that have been published in peer-reviewed medical journals such as New England Journal of Medicine or JAMA. So if this is their standard for determining whether the care you provided should be covered or should be paid, then that's the same standard we should be looking for when we are arguing that care should have been covered or should have been paid. Okay. So as an appeal writer, a lot of times, that's what we're charged with doing, is trying to draw those parallels between, look, the care provided does meet the standard of care in the medical community, and thus it should be appropriate for payment. Okay, so let's look at what some of the commercial payers say about standards of care. And commercial payers publish what they call, they may call them other things. They typically call them clinical policy bulletins. They may have other terminology for that. But again, these are articles that they publish that say, this is when we cover your care, this is when we pay for services, and this is when we don't. So Aetna says when they develop their clinical policy bulletins, they look at peer-reviewed published medical journals, they look at available studies on particular topics, they look at evidence-based consensus statements, expert opinions of healthcare professionals, and guidelines from nationally recognized healthcare organizations. Okay, that's pretty good. I kind of like that list.
And Denise, I would chime in and add that you'll see these denials from the insurers. They'll be denied typically with remark as experimental. The insurer, if they feel the CPB has not been met, will deny the care as experimental and investigational. So that may be your tip-off that a CPB was involved in the denial.
Yeah, good point. Okay, CPBs are typically developed around mostly outpatient services, not all outpatient services, but let me say they're developed for procedures, therapies, services, medications, things like that. So some of our payers do have policies around inpatient versus inpatient admission, inpatient patients versus outpatient, but the vast majority of clinical policy bulletins are going to be around procedures, services, surgeries, things like that. Okay, Anthem Blue Cross and Blue Shield says that their medical policies generally apply to all of Anthem's plans. So I guess we're left to guess which ones they apply to, which ones they don't. I don't know. Local variations may exist. I understand, they're kind of they're all over the country. Maybe there's different ways that doctors practice in one part of the country versus another. Anthem has developed clinical UN guidelines, utilization management guidelines, but they've also licensed to use MCG guidelines. Okay, so which one are they going to use? And when do they choose which one to use? But this one also is one that's kind of a puzzler. They say they also have the right to customize MCG guidelines based on determinations by their Medical Policy and Technology Assessment Committee. I've heard discussion about this a couple of different times in the community about does MCG know that? Did MCG approve Anthem to customize their guidelines? So there's a lot of debate on whether that's actually kosher or not that they do it or have done it, and whether MCG was okay with it or not. I don't know. I can't speak to that. And then United Healthcare says that they also use generally accepted standards of medical practice. They use credible scientific evidence published in peer-reviewed medical journals. things that are recognized by the relevant medical community, standards based on physician specialty societies, et cetera, and then other evidence-based industry recognized for resources and guidelines such as MCG. Okay, so they use a little of both, I guess. And Interqual and MCG, I'm not here to bash them in any way. They are based on standards of care. Obviously, they're not just making the stuff up that they publish in Interqual or MCG. But just saying that if your payer is going to review the services that you're providing, and review your medical records to determine whether that service is covered or determining whether they're going to pay for those services, you ought to at least know what they're using, right, to do those reviews. Okay, so let's talk about okay, I just got muted real quick there, and now I have an echo. Okay, is it still there? Kendall, are you hearing an echo?
It's a little bit. It's workable.
Okay.
You can go ahead. Yep.
All right. I'm not sure what's going on there. Okay, so let's talk about if you accept a commercially published care guideline as the final word in medical necessity, what chance do you have to appeal a denial? So I'm not talking about if your payer used a care guideline to determine whether they're going to cover your service or not, and they applied it inappropriately, incorrectly, used the wrong guideline, and you can appeal that by pointing that out to them, then by all means do that. I'm not saying to abandon that particular process. I'm just saying if they used a care guideline and it actually did not meet, and you need to argue that in your appeal, then you need to go to standards of care to make that argument. Okay, so all payer guidelines are based on acceptable standards of medical care in the community, including Interqual and MCG. But they are screening tools and they're not endorsed by Medicare. So I just want to throw that out there. And I know, Kendall, you want to talk about Interqual, MCG, and then our next slide is going to be on NCQA as well.
Yeah, so as Denise mentioned, Interqual and MCG or Millman are used as screening tools. And in fact, when you look at the forward or the preamble to Millman, and this is also I've seen with Interqual, there's a paragraph that describes the limitations of their use, sort of a caution, and it states that the care guidelines are developed for an idealized patient in an ideal hospitalization with ideal follow-up and control of their comorbid illnesses. So the limitations that are self-described, and actually one of Millman's MCG's medical directors had published an article some time ago in the press, kind of echoing the same thing, are important to keep in mind and to point out to the payer. So as Denise mentioned initially, if you can show that the guideline was applied incorrectly and your patient fits the guideline, there's no need to argue further. However, if the guideline fits the case at hand or just the diagnosis at hand, one of the strategies we talk about using is reminding the payers of the limitations that both Millman and Interqual put on their products, and saying that, my patient is not the idealized patient that Millman or MCG or Interqual described. This is a unique patient, multiple comorbidities, bad social circumstances, and as such, applying MCG or Interqual in this case, would be unfair and improper. So it's a real just reminding them of the limitations of the product and showing that the patient at hand is not best served through the application of an MCG or an AQUAL guideline. NCQA, so NCQA and URAC are to insurers as TJC or Joint Commission are to hospital organizations. They're certifying bodies that go and look at insurance companies, their utilization review and case management processes. URAC or NCQA certification are necessary for insurers to participate in Medicare and Medicaid programs. So they really need to be careful that they are abiding by the rules. And when you actually go into the NCQA UR criteria, what Denise has pulled up is a discussion of the appropriateness and use of standards of care by the insurance organization, so that they need to have decision-making criteria that are objective and based on medical evidence. And I think that's one of the significant things that we're discussing today, is how to bring objective medical evidence into the appeal process. More importantly, number 2, has written policies for applying the criteria based on individual needs. This echoes what we've discussed already, that you can't take a one-size-fits-all approach to a particular patient. And then even getting more specific, you have to look at local delivery systems. So if you're a rural hospital in Appalachia, for example, or in the Ozarks, with limited follow-up, limited social services, you have some unique circumstances that really need to be brought to the payer's attention in the appeals process. And then, of course, they need to have appropriate oversight in adopting and reviewing criteria. Denise had mentioned Anthem's policy or right to go in and revise a Milliman. According to NCQA, if that is going to happen, then it has to involve appropriate practitioners in modifying the criteria. So probably board certified specialists would need to participate in that process. And then an annual update to their procedures. One of the things that I will tell you that we do, or I do personally quite regularly, is advise the insurer, if I view that they're stepping outside of these guidelines, that we'll file a complaint with NCQA and let the NCQA come in and investigate their processes and decide. Sometimes it does get significant attention. So it's certainly another card to keep in your deck, and just consider it for that appeal where you feel that the insurer is not acting appropriately or reasonably. And there are outside organizations that will help and intervene and review that circumstance.
Okay, good. So one of our viewers reminded me in questions that UHC is following InterQual as of May and June. So thanks for pointing that out, keeping me honest. That's a failure on my end to update my slide. But thank you for that.
They actually purchased InterQual, so not even a question of using it. The parent corporation owns it.
Yeah. Okay, so researching our standards of care. When you go out looking for what is the standard of care that I can use in my appeal argument, some of the credible sources I would recommend, professional guidelines, as we've talked about a little bit, published research studies, peer-reviewed journal articles. There's PubMed, National Institute of Health, sources of professional reference such as Medscape, manufacturer's information. Let me talk about this for a second. The first time I had to do an appeal for the Watchman device, I wasn't that familiar with it. I'm looking through the medical record and I see that there's a name and a phone number of the rep from the company who was there at the time the Watchman was being implanted. So I called him up and I said, what can you tell me about denials for this procedure? And he gave me the name and the phone number for someone at the manufacturer to talk to. And this lady, that was her job, was to talk to providers about how to bill for it, what's covered, what isn't covered, what denials they were seeing. And it was just very helpful to kind of get me on the road or on the right track to develop my appeal argument for that. So don't forget about checking with the manufacturers. Government and agency alerts, electronic healthcare updates like AHRQ, and then sometimes textbooks work. So what I always think of as kind of the gold standard when I'm looking for the standard of care is I'm going to go straight to that physician professional society that would be involved in that particular care, like the American College of Cardiology or American Academy of Orthopedic Surgeons. So this is just a screenshot of where you can find the guidelines from the American Academy of Orthopedic Surgeons. These are free, you can download them, you can use them in your appeal arguments, you can quote them, you can use them to start developing your library of appeal arguments. They're usually only 1 or 2 clicks into the website. Don't have to be a member to get them. Here's American College of Cardiology, just to give you another view of one of the specialty society websites where you can find guidelines. Okay, so when you're looking at articles that you want to use, think about, does that particular article address the patient's nuances? Is this patient who came in with congestive heart failure, is this a new onset of CHF? Is it chronic CHF with an exacerbation? Does the patient have chronic renal disease along with it? So different articles, sometimes they're going to address different patient situations. Does it support the medical necessity or prove the need for admission or treatment? Now, it's not very often that you're going to see articles that come right out and say the patient needs to be admitted for this condition or that condition. You will see that in some, and that's a gift when you see that. But the article can talk about the risk of a patient presenting with a particular condition deteriorating rapidly or needing a certain amount of time in the hospital to get turned around. Other things, rather than just coming out and saying they need to be treated in the hospital, there's other things in the article that can help support why they need a hospital admission. Think about whether the article was published before the denial date, because of course if it was published after the denial date, you probably don't want to use it to say that was the standard of care on the date that your patient was admitted. Does the article cite the most current or established criteria? It doesn't mean that it's outdated, just if it's a little bit older. Think about, let me start over again. The clinical policy bulletins, that echo's just throwing me off. Clinical policy bulletins that are published by the payers are updated annually. From my experience, when I go in and look at a payer's clinical policy bulletin, Aetna, UHC, whoever it is, you'll see they are updated or at least reviewed annually, 1 day or 1 year, 365 days from the last time it was reviewed. I mean, they are just on it. I don't see that so much for the national coverage determinations or local coverage determinations that come out from Medicare. Sometimes those don't get updated until they actually see that there's a change in practice. They don't get reviewed on a regular basis sometimes. So when you're looking at an article, you want to think about, is this the most current or established standard of care? And does it mirror what's published in the clinical policy bulletin, the LCD or the NCD? And then we try to stick with articles that are from countries that practice medicine like in the US. Okay, so start an electronic library to save your favorite articles, quotes, and arguments, and that's what I'm going to present in November during the webinar then. make it accessible to everyone who's working on appeals, update it consistently, make it easy to copy and paste from. I cite my references professionally using APA format. If you're not familiar with that and you want to do it, there are a lot of free websites out there that will allow you to get the APA reference by just entering the URL for the website where that article is located, or just entering the author's names, the name of the article. It will return to you the reference in APA format, which is pretty nice. So BibMe is just one of them. I don't have any connection with BibMe. Purdue OWL is an online writing lab I use sometimes as well for APA formatting. And then create snippets of those articles that include only relevant information. You just want to talk about the pieces of your peer-reviewed journal article or standard of care that's going to help support your argument. Okay, so let's talk about a couple of examples of these. Here's one for asthma. This is from the National Heart, Lung, and Blood Institute. And it talks about how serious exacerbations of asthma may require a hospital admission. Now, when a peer-reviewed journal article talks about hospital admission, I would argue all day long they mean inpatient admission. Okay, that's what I would say. They are not going to develop standards of care or journal articles that say a patient needs to be treated in the hospital or outside of the hospital, and talk about whether that patient treated in the hospital should be inpatient or outpatient in a bed. I mean, it doesn't make sense that they would say, oh, they can be treated as an outpatient, and that means take them to the hospital and put them in a bed. If they're saying take them to the hospital and put them in a bed, they need inpatient, hospital admission. I would argue that all day long in front of an administrative law judge, arbitrator, administrator, you know, anyone outside the payer's court of opinion, that that's what they mean. Obviously, they're not going to write articles on how that care should be paid for. Okay, so this one talks about how severe asthma exacerbations are likely going to result in a hospitalization, and a severe asthma exacerbation is defined as dyspnea at rest that interferes with conversation, peak expiratory flow of less than 40%. Well, how many people are doing a PEF in the ED? I mean, you can, but I don't see that very often. But you can look at, are they dyspneic at rest? Are they too dyspneic to speak? Are they perspiring? That's life-threatening exacerbation that requires hospitalization and possibly even ICU. So that's an example of how some of these standards of care articles can help support that this patient did need a hospital admission because they presented with severe asthma exacerbation or life-threatening exacerbation. Okay. Then it goes on to say patients at high risk for death from asthma include, and then you've got a whole list of things to look at that make your patient at a higher risk for death. So maybe you don't have the dyspnea at rest, maybe they're able to converse okay, but they've had 3 or more ED visits for asthma in the past year, or they've been hospitalized for asthma in the past month. So those are other things to consider in your argument on why this patient might have needed the inpatient admission or did need the inpatient admission. Okay, so here's one for atrial fib. This comes from the American College of Cardiology, American Heart Association Task Force on Practice Guidelines, and the Heart Rhythm Society. This one doesn't come right out and say this is when a patient needs to be admitted to the hospital, but it talks about some risk factors and things that a physician may consider when he's making that determination to treat a patient as an inpatient. So it talks about how a patient who has frequent hospitalizations, hemodynamic abnormalities, and thromboembolic events related to AFib result in significant morbidity and mortality. AFib is associated with fivefold increased risk of stroke. AFib is also associated with a threefold risk of heart failure, twofold risk of mortality. Initially, asymptomatic patients may develop tachycardia-induced ventricular dysfunction and heart failure, etc. Okay, so let's do a little case study. This one's for diabetes. This was an actual case that was appealed and was overturned at level 1, I believe. I think you'll see why. I mean, it's pretty much obvious that she needed to be an inpatient. But just to show you how you connect your standards of care in your argument. So on May 25th, 2020, Jane Doe, 63, known diabetes, controlled with oral medication at home. She presented to the hospital ED with a high blood sugar reading from her home glucometer. She was suffering from polyuria, polyphagia, polydipsia. Her glucose level in ED was critically elevated at 894. And she had a significantly elevated anion gap greater than 30, indicating metabolic acidosis. Abnormally high BUN of 40, and abnormal creatinine of 2, indicating renal insufficiency. And she did not take insulin at home. She didn't have insulin ordered at home. She was just on oral medications. So she was emergently treated in ED with IV fluids with potassium, an insulin drip, IV magnesium, IV phosphate, and oral potassium. And she was admitted to the medical intensive care unit with diabetic ketoacidosis and acute kidney injury. So let's look at one of our standards of care for diabetes. This comes from the American Diabetes Association, and it comes right out and says, our indications for inpatient admission: life-threatening acute metabolic complications of diabetes, which I would say she had, substantial and chronic poor metabolic control, necessitates close monitoring to determine the etiology of the control problem and subsequent modification of therapy, which is actually what occurred with this patient. She was converted to insulin therapy and sent home on insulin therapy. Diabetic ketoacidosis and hyperglycemic hyperosmolar state. Now, one way that you can use this in your appeal letters is to, in your narrative, talk about how the American Diabetes Association says patients who present with blah, 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 1, 2, 3, 4, which this patient had, that's an indication for an inpatient admission. Now, this one actually comes out and says inpatient admission. Usually they just say hospital admission. Or because we have to be not only effective in our appeal writing, but we have to be efficient. We can't spend hours and hours writing our appeal letters. You could put it in your letter in a table format or not a table format if you don't like working with tables, and just bold these snippets that are relevant to this particular patient. So you can develop templates that have this standard of care snippet in it, and then you just bold what applies to your patient. Makes it a little bit quicker. Okay, so let's talk a little bit about outpatient denials and appeals. So we talked about clinical policy bulletins published by the payer. So if there's a denial for a procedure, surgery, a service, the first thing you want to do is look to see if there's a clinical policy bulletin that's been published by your payer. One of the things that I look at first is I look at the diagnosis code that was submitted on the claim and see whether that is included in the clinical policy bulletin, because sometimes that can be a quick, easy appeal to say that this diagnosis was covered or not covered by the clinical policy bulletin. Sometimes the patient has another diagnosis, not a different diagnosis, but another diagnosis that is more appropriate, or is covered by the clinical policy bulletin, but it isn't the one that was submitted with the bill. So that's an easy appeal. Is there additional documentation needed to support medical necessity, such as physician office notes? So we see that quite a bit, where we don't have everything that the physician documented in his office about why this patient needs physical therapy services or cardiac rehab or whatever. So we want to make sure that we get all of that documentation together, make sure the payer has that. Was that additional documentation sent in response to that payer's request for your records on your, or did you send it on your first level of appeal or reconsideration? So best practice is to verify the documents that were sent by keeping copies exactly of the medical record you sent so that you know whether they received those or not. Now, there will be times when not all of the supporting documentation meets all of the required elements of that clinical policy bulletin. Maybe there's a reasonable explanation why. Why did that patient not go through physical therapy for a period of time prior to the total knee replacement surgery? Is there a reasonable explanation why they could not participate in physical therapy? So don't think just because your documentation doesn't meet all the required elements of the CPB that you can't appeal it.
And these may be cases too where reaching out to the attending physician and getting a note or a letter clarifying the issues that Denise brought forward why the patient couldn't meet the CPB, or adding additional documentation that you find is missing that could reasonably be provided in an attending attestation statement may be helpful. They are very time intensive, sometimes for the dollars recovered, but they are generally recoverable if you can involve the attending or the clinician that ordered the procedure and have that discussion with your office.
Okay, so let me just show you walk you through an example. And I just picked blepharoplasty just because it's fun to say. This could be for Botox injections or physical therapy or any other services you provide at your hospital. So we're looking at the clinical policy bulletin from United Healthcare for blepharoplasty, which is eyelid surgery or eyelid surgery. So we'll see in the clinical policy bulletin, they have a section called documentation requirements. So we're going to go there, and this is where there's just kind of a short summary of required clinical information to support blepharoplasty, blepharoptosis, and brow ptosis repair. A lot of big words. You can see the CPT codes are on the left-hand side. Those are the ones that they're saying are covered. Just because your patient has one of those CPT codes doesn't mean it's an automatic coverage. You still have to meet medical necessity documentation in the medical record. And the one that I have an arrow drawn to is the fourth bullet point that talks about visual complaints, functional impairments, and ruling out other causes. The other things they have listed here are things like results of automated or manual taped and untaped visual field testing, marginal reflex distance. Those are tests that are probably going to be performed by the physician as he's thinking about doing this procedure. And that's going to you're going to find it in the medical record. It's just going to automatically be in there. But where is the documentation from the physician about the patient's visual complaints, about their functional impairments, about any other causes of this condition that may be treatable without going to surgery to treat it? You're going to see that all the time for clinical policy bulletins for medical necessity. What are the functional impairments of the patient that support the need for this particular procedure, surgery, or whatever it is? And that comes from the physician's documentation. Okay, and then just going on, this is additional criteria that would be required if you were going to bill for an upper eyelid blepharoptosis repair. And you can see where it talks about the member, meaning the patient, must have a functional or physical impairment complaint directly related to position of the eyelid, and other treatable causes of the ptosis are ruled out. So maybe they had a recent Botox injection that's making their eyelid droop, or maybe they have myasthenia gravis. So that's the documentation that the payer is going to be looking for in your medical record. And then at the bottom of your clinical policy bulletin, you're going to see references that that particular payer used to develop that clinical policy bulletin. So these are your standards of care. And we can see these were published in 2007, 2005, 2012, so they're probably pretty up to date. But if you're starting a evidence-based guideline library or standards of care library, this is a good resource to kind of get started on your search of where do I look for standards of practice for this particular procedure. Well, one of them would be American Society of Plastic Surgeons. That's the first one listed on references. Okay, let's talk briefly about Medicare, CMS. They have a Medicare coverage database where all of their national coverage determinations and local coverage determinations are stored. An NCD published by Medicare will apply to all Medicare beneficiaries. An LCD will only apply to the beneficiaries within the MAC jurisdiction that published that particular LCD. And this is what the MCD database looks like. They've updated it just in the last few years where it really is nicely easy to use and find what it is that you're looking for. So I just put in for my search BLEPH, BLEP, and then I get the results of all the LCDs and any NCDs that might apply to that particular procedure. Okay, so the best practices to prevent denials, develop payer-specific checklists for your pre-procedure documentation review to start with your top 5 payers and say, whenever a patient comes in for a blepharoplasty, I want to make sure I have all this documentation in the medical record before I schedule that patient for a blepharoplasty, because then I know we're going to get paid. Engage your department heads to support your pre and post procedure documentation audits to make sure you're meeting those goals of making sure that documentation is there. Educate your providers and their staff on documentation requirements. And Dr. Smith, did you want to talk at all about pre-procedure documentation review?
Sure. So one of the things that we see coming down the pike is sort of a merging of denial specialists and CDI and utilization review into what we start to discuss as being PDI, payer documentation integrity. Essentially what we're talking about is making sure that all the necessary boxes have been checked according to a payer guideline before a procedure is undertaken, with the realization that many of these things can't be done after the fact. So for example, CMS has a NCD, a national coverage determination, that says prior to putting a defibrillator in a patient, a shared decision-making tool has to be signed by the patient and the attending. And that shared decision-making tool basically educates the patient about the risks and benefits of the defibrillator. Medicare knows this is a area that's ripe for auditing, and they will generally do post-payment audits on these and recoup these if they don't see the documents on the chart. So the best practice, as Denise has alluded to, is getting a process in place with your UR, your CDI staff, where you're taking this information from the back end that you're seeing on your denials and getting a process in place on the front end. Ideally, there are software, there are programs that are able to provide alerts to the attending in the clinic when they're ordering say, booking an OR schedule for a pacemaker or a defibrillator, provide them an alert through the EMR that there's a checklist that needs to be completed. It's seamless, it's painless, it can't be done after the fact. And so there are resources out there available to be able to assist and help denial-proof charts and denial-proof cases.
Okay, so we're running right up to the top of the hour, so we're going to wrap it up here. Put your questions in the questions. We'll grab those at the end and answer those with a presentation type thing that we'll have on our website in a couple of weeks. So our takeaways for today: standards of care are informed by systematic review of evidence and assessment of the benefits and harms of alternative care options. All payer guidelines are based on acceptable standards of medical care in the community. Use credible sources to research your standards of care. We'll talk about that a little bit in November at our next webinar. Create snippets from the standards of care for support of the medical care provided, and harness the power of standards of care in your appeal arguments. I just want to say happy CDI week. There are CDI folks out there. I know we have quite a few who are members of ADAM. Just a reminder, if you're looking for that active CEU, I haven't gotten approval yet. That's the only one I haven't gotten approval for. I'm still working on it. Go ahead and mark if you want the active CEU, and I will do what I can to try to get that for you. Thanks to our support staff at the corporate office for helping us out. They always do a good job. And then here's our contact information. If you have any follow-up questions or anything you want to share with us, we're be glad to hear from you. So here's our email addresses. All right, thanks everyone. I hope you enjoyed this presentation. We'll see you in November. Go to our website now and sign up for that one. You guys have a great rest of your day, rest of the week, and we'll see you again soon.